Welcome to Times Conversations. I am Paloma and today's topic is diabetes with the expert team from Parvathy Hospitals. I would like to take a moment to introduce them. I'd like to welcome today Dr. J. Dharmarajan, Head, Foot and Ankle Institute, Parvathy Multi-Specialty Hospital. Welcome, Doctor. He has over 26 years of experience in orthopedic surgery and 7 years of specialization in foot and ankle care. And we've heard that he's a compassionate expert dedicated to providing comprehensive care for foot and ankle trauma, deformities, disorders, and more. We also have with us Dr. S. Narayanamurthy, Head of Department and Consultant here, Plastic and Reconstructive Surgery, a highly accomplished plastic and reconstructive surgeon with over a decade of experience. Welcome, Doctor. We also have with us Dr. Sai Vigneswar, Consultant, Internal Medicine and Diabetology. There's going to be a lot of questions directed your way, Doctor. Welcome. Thank you so much for joining us. And we have with us Dr. Vishal H., Consultant, General Medicine and Diabetology. Yet again, a dedicated physician with expertise in diabetology and infectious diseases. Also committed to patient-centric care and evidence-based medical practice. Welcome, Doctor. And rounding out the team, we have with us Dr. S. Prathap, a vascular and endovascular surgeon with keen interests in quality vascular interventions using modern scientific knowledge. And I'm going to say welcome, Doctor. Thank you all so much for taking the time to join us today. It is a vast subject, so I think we will dive right into it, starting off with our experts on the subject seated to my left. So I'm going to start with Dr. Sai Vigneswar asking the bigger question, and I think the most asked question from the public, which is, when does somebody know that they're at risk for diabetes, or what are the early symptoms of diabetes, and how does somebody get started on solving this problem? So Doctor, I'll start with you on this.
First and foremost, like diabetes per se, earlier it used to be a pathological disease, and now it has more become like a lifestyle kind of a disease. So when you come to diabetes, it's not just the diabetes, it's just what happens before when you get diabetes. So that's when the question of early signs and symptoms comes into the place. And if you ask us, like, to be honest with the technical term, we call it as pre-diabetes. So pre-diabetes is where we urge, especially our Asian population, to focus on the signs and symptoms, to pick the signs and symptoms so that the chances of you landing on a full-blown diabetes is going to be less. And the most important challenge we as Asian population, as a rice-eating population, faces is the amount of people living with diabetes has increased to almost like 15% of entire population. If our population is growing from 135 to 140 crores, the 15% of the population right now is living completely with diabetes, and they're also facing and challenging the complication of diabetes. So if you want to pick the early signs and symptoms of diabetes, we have to start from a state called pre-diabetes. So pre-diabetes is what, especially the millennial generation, the generation that spends most time on the screen, this generation that spends more time at home, where they work from home, where they do all their purpose from home, where they order to home, is suffering from and is starting from. So when you start with pre-diabetes, the early signs and symptoms, as many of the people are now aware, is you're going to have signs of increased menstruation, there's going to be an increased appetite, or we call hunger pangs, and then again it's going to be increased urination. So these three symptoms, as everyone knows, is going to be there even when you are going to start as a pre-diabetes. But most common symptoms that nowadays which we are seeing, especially in the younger generation, in the group of 25 to 35, which is very surprising, is it starts with mood swings. It starts with enhanced mood swings. And when you come to the female population, it starts with an irregular periods, hair loss. And a very typical signs that we are able to pick in the recent times is a difficulty in perceiving the long vision than the near vision. Okay. So this is one sign that we are picking in the recent times, because most of the times, since the population between 25 to 35, why I am keeping on insisting on 25 to 35 is that is the generation that is going to be the important generation for the future. And that's the generation where we have to pick diabetes at an early stage. Once they come into the stage of 35 or 40 is where the problems with diabetes or the complications of diabetes is going to increase.
I think at this age, people don't even do a master health check. Usually 40 is the number that comes up when people talk about even checking things like this.
Exactly. So when you compare to the European population, where you have to get a colonoscopy study done, no matter what, at the age of 35, here if we have to make a person do a master health checkup at the age of 25 is a big task.
Yes.
So that's why we want to focus more on the early signs and symptoms, more on picking patients where it can be reversed or remitted is very important sign. So the common symptoms that we see is always going to be polyuria, polydipsia and polyphagia, increased appetite, increased urination and increased fatigability and increased thirst. But apart from this, the signs that people have to focus more on is unnecessary mood swings, unnecessary weight loss, unnecessary symptoms related to their periods and muscle loss. And if a person is finding it very difficult to gain weight, we have to be aware. At the same time, if a person is finding it very difficult to lose weight, is also we have to be aware. Because the knowledge on muscle is very low, especially when it comes to Asian population. Because if you feel someone chubby or someone gaining weight, people feel like they are healthy. So we have to start changing that perception. What we have to focus is, they might look healthy to you, but what is the amount of muscle mass that they have? When a person starts losing muscle and starts gaining fat, that's one early sign of diabetes. So that's when the real diabetes and the diabetes related signs and symptoms comes into the picture.
Okay, yeah. So I'll sort of continue with this, talking to Dr. Vishal, and ask you, what are the other complications that arise from diabetes, and how are the other parts of the body affected, like maybe the eyes, the kidneys, or even the foot?
Okay, so diabetes, it's a very long-term process. A disease, initially it doesn't present any symptoms. So what happens is, once the duration of diabetes increases, like if the patient is diabetic for 5 years or 10 years, what happens is he starts to develop some complications. And when the sugars is uncontrolled, the complications set in little early also. So what we usually say is, the most common problem the patients come with will be main cramping pain or some burning sensation in the feet. These are main complaints they come in. Other complaints which can happen is, it can affect the eyes. It can cause one thing called as retinopathy. It's very silent. It won't show any symptoms initially. So what happens is, if it is not controlled properly, it can even lead to vision loss. So very important to catch up this retinopathy very early. And other complaints which can happen, more major complications, one will be the heart disease. So again, we know that our population, younger population, are facing a disease like heart attack, everything.
Yes.
More frequently, more earlier than it used to be in the ancient times. So right now what happens is, it's very difficult to manage your heart also. Again, one more symptom which I was saying earlier, right nowadays, is the stroke. So many patients are present, younger patients are present with stroke also. So all these are due to diabetes only. We are being uncontrolled diabetic, unknown diabetic patients are present with heart attack. They are present only with stroke also. So these patients would have started getting sugars pretty early. So then it becomes very important to screen them early. Again, most of the patients being diabetic, dialysis, kidney issues is very common. So most are diabetic, if it's not controlled, again they land up into kidney complications and maybe requiring dialysis if it's untreated. Other issue which can cause us the nerve problem with the neuropathy, which can lead to foot complications, foot ulcers, and many people, if it's untreated, can go into amputations also, like losing the fingers. All these can happen in diabetes. The most major complications are there.
Okay, so I'm going to sort of pick up with your last answer and direct a question to Dr. Dharmarajan. So doctor, talking about in a chronic diabetic patient, how do people develop these ulcers in the foot? Is it manageable is the first question, and how can it be cured?
Yes. Patient developing ulcer is mostly not because of direct injury or direct hurt. Diabetic feet is a combination of neuropathy, that is the affection of the nerves, vasculopathy, that is the affection of blood vessels and the microvasculature of the foot, as well as the bones of the joints. And not all the diabetic patients may end up in diabetic foot. Those having this type of neuropathy, because that is terminology is called insensate foot. Even a small thorn prick, if normal patient walks, the defense mechanism will be there. Even walking on a hot areas on the roads, they take off the feet immediately. Where an insensate foot, that is the sensation is diminished or lost, they keep on walking on a rough surface or sand particles or stone particles, they get frequently injured, and then even a small slip fall, they develop because of the pain perception is very low because of the neuropathy. The magnitude of the fracture looks like a high energy, which is equivalent to a road traffic accident fracture. So they keeps on walking on a deformed, painless foot and joints. They develop the integrity of the joint, the loss of the arch is gone, the arch is lost, and then keeps on a disorganized bony structures where they develop multiple ulcers, and the management part will come back after Dr. Narayanamurthy's intervention. This is the way they develop ulcers in the foot because of the neuropathy, vasculopathy, and disorganized architecture of the joints of the foot.
So I'll come to you, Dr. Narayanamurthy.
I would like to add on a few points to what sir has already mentioned. Sir has nicely elaborated the various factors that are involved. I would like to just give a brief outlook about how an ulcer forms. Because being a plastic surgeon, mostly complex wounds we generally treat. So we would like to address to the listener about how an ulcer forms, because as sir has mentioned, there is a problem with blood flow. So the blood to that feet, which is the most distant part of the body, is affected. Then there is a problem with the nerve conduction, which means the sensations from the tip of the toe is not being effectively transmitted to the spinal cord and then to the brain. Then there is a problem with flow properties of the blood, which means the cells within the artery or the vein, they flow in a particular pattern that can get affected. The cells can get clogged up to each other, which can reduce the blood flow further. Other problem is the ligaments and joints, they become lax. So when the ligaments and joints they become lax, what happens is the normal biomechanics of the foot is deranged. So when the patients walk, the entire weight of the body is borne by the foot. So when they start walking forward, when the weight of the body is borne by the foot, our foot is designed in such a wonderful manner to effectively bear the weight without causing any derangement of the biomechanics of the foot. But because of the effects of diabetes and high blood sugar, this biomechanical arrangement is deranged. When this biomechanical arrangement is deranged, the pressure points they shift. So parts of the foot, the points of the foot where you don't expect higher pressure points, they get exposed to higher pressure points. So this parts of the foot which are exposed to higher pressure points, they are not generally adept to feel that amount of pressure. So that area, what happens is the body tries to compensate for it. So the thin in the sole of the foot, the undersurface of the foot, we generally say in the undersurface of the hand and the foot, we see that skin is little different when compared to the other parts of the body. This we call as glabrous or thin skin, so thick skin. So this thick skin, when they keep rubbing against the deranged pressure and the pressure on the foot, there are two hard surfaces in between, two hard surfaces sandwiching the soft tissue. So when there is constant contact and abnormal pressure on that particular area, the skin thickens. So we might have seen the thickening when we play tennis or any racket sports, very similar to that. So the skin thickens and this forms a swelling kind of a thing, hard swelling kind of a thing. So this further complicates the pressure mechanism. So what happens is between the skin and the bone, a cavity forms, which is a space like thing which is filled with fluid. So this cavity gradually expands over a period of time as the patient keeps on walking with the barefoot. So the point to be noted is ulcer forms because the general everyone knows that ulcer forms because of lack of sensation in the feet. So because of lack of this system is already there, the cavity is already there. So when because of lack of sensation, when there is a small thorn prick or a very trivial injury, what happens is this thorn prick or injury opens up that cavity from inside. So that is when most of the time when we see the patients in the OPD, they will say, sir, just 2 days before we got an injury, but within 3-4 days the wound has become so big. So it is never that way. It is because the cavity was there already inside, existing cavity, and the injury has just opened it up. So this is why it is extremely important to address each and every etiological factor. So the blood flow should be managed properly, corrected, and we need to increase the blood flow to the feet. The nerve, if there are any compression to the nerve at certain points, there are certain points where the nerve can get compressed. So those points need to be released to increase the flow along the nerves to improve the sensation. And then the soft tissue management needs to be done along with the bone and ligament management. So when we offer a comprehensive treatment to it, then we'll be able to get reversal and of the ulcer. We can cure the ulcer then we can even salvage the feet and make them walk on their own feet. So the goal of a diabetic foot management is always to salvage the feet and allow early rehabilitation so that the patient gets back to his normal routine as early as he can.
So doctor, maybe you could tell us a bit about the role of a plastic and reconstructive surgeon in diabetic foot care.
Yeah, this is a very important question. So the role of a plastic surgeon is very similar to the role of the captain of a ship, because the most common problem with diabetic foot is the most common way it is managed is all this while the traditional way of managing foot. Anybody talks about any surgical procedure for a diabetic foot is always about amputation and debridement. Debridement means cleaning up the wound. So the commonly practiced techniques are just cleaning up the wound and cutting off from fingers, and slowly it keeps going up. So this is because the treating surgeon does not anticipate how this is going to end. So the destination, that is why I say we perform the role of a captain of the ship, because that we understand how this is going to end, because we understand how we are going to clean. After the wound is cleaned up, we know how we are going to cover it up. How we are going to reconstruct the wound. So when we effectively reconstruct the wound with good tissue which has got good vascularity, good blood supply, then that tissue is going to be a durable one and it's going to stay for a long duration. And this allows rehabilitation and early return to work. Okay. So this, because we end up, plastic surgeons are also called finishers. So we finish any problem. So that is why, because we know where it is going to end, it is important that we start getting involved in diabetic foot management much earlier.
So let me come to Dr. Prathap here, and I think we've now understood the importance of the vascular system and blood flow, which is something maybe we don't initially think about when somebody talks about diabetes. So doctor, perhaps you could shine a little bit of light on this for the general public, for them to understand this a little bit better and how it plays a role.
Actually, in the management of diabetic foot syndrome, as we call it, the often neglected topic is the peripheral vascular disease. So peripheral vascular disease, we have to know the magnitude of the problem first. As we are speaking, in every 30 seconds, a limb is lost in the entire world. So that is the magnitude of the problem. Next important thing is a patient who is having a diabetic foot for at least 10 years, he is liable to lose his foot at around 25%. So that's a very large proportion. So as a vascular surgeon, we have to take care of the macrovascular part. My colleagues had discussed about the microvascular complications, the kidneys being affected, the retina being affected, and also the nerves being affected. So we also have to take care of the peripheral pulses. That is, any vascular structure apart from the heart is called the peripheral vascular system. So we have to understand that I have to give a palpable pulse across the ankle to salvage the limb. So we have also launched campaigns such as Amputation Free India in regard to this. So in diabetic patients, you see that the diabetic foot syndrome affects bilaterally, and it is symmetrical, and it affects the below knee segment. And we have modern methods of treating it like angioplasties, bypasses, but we have to detect this disease in the early segment. So the guidelines suggest that any patient who is above 40 years, we have to screen them for the presence of peripheral vascular disease by means of an index called the ankle brachial index, and we have to make sure that their risk factors, like they might be smoking, they might have hyperlipidemia, hypercholesterolemia, all those risk factors are taken care before they are subjected to any procedure. In that way, we can have a holistic treatment for the patient, and we can make sure that the diabetic foot syndrome doesn't progress into amputation. So that will be a primary.
So Dr. Dharmarajan, coming back to you, from a patient's perspective, how does one take care of the foot if one has been diagnosed with this?
Yes. One thing is, every patient in the high risk category, or actually the physician would have warned them that you have this sensory loss of the foot, or this peripheral vascularity. They have to inspect the feet on a regular basis. Easy way is while taking bath, they have to inspect for corns. They call some hard pointed hardening of the sole of the foot. The corns and the callosities, as Dr. Narayanamurthy told, the tough hard skin of the sole of the foot, they have to inspect whether it is increasing in size or it is become a soft and there is any fluid collection, immediately they have to consult a doctor. And then once some corrective surgery has been, the foot has got three components, that is called forefoot, the midfoot and the hindfoot, where the back of the foot. Any of the ulcers or the scons or callosities occurs in the forefoot, they should consult a orthopedician or a plastic surgeon to have their custom made modification of the footwear so that they can offload where the problem is. Offload means that area the pressure is taken off by doing various methods, clinical examination, weight bearing x-rays and then pressure plate studies. Okay. So they have to change the footwear custom patient specific custom made footwear, and the main thing is they have to wear the footwear at home also. They should have at least 2 sets of footwear, one for outside, one for inside, and then periodic inspection of their foot. This is the way.
Do we feel that there's also a little bit of fear mongering, that the moment someone mentions diabetes and the moment someone mentions foot, as Dr. Prathap was saying, amputation is the word that comes to mind. So is there some misconception that needs to be cleared here?
Yes, it has to be cleared. Most of the patients in full-blown late presentations, they have the fear of this amputation. But as Dr. Prathap said way back 2 or 3 decades back, only one surgeon or one physician will be attending the diabetic foot ulcers. Now the day has come, the science has evolved, and so that there is a team approach. That is what we set up in Parvathy Hospital. Padam, it is a holistic approach, a comprehensive networking and collaboration among us, so that the soft tissue part is taken care, the medical part is taken care, surgical part is taken care, and then further prevention of ulcers. So the idea is that, as Dr. Prathap told, the number of amputation occurring for the past 10 years has drastically come down.
So Dr. Dharmarajan had mentioned that you all work as a team, so I'm curious if you all could shine some light on, once somebody is diagnosed and a patient enters the hospital, what are the different facets and how do you all work as a team here at Parvathy Hospitals, if you all could shine some light on that, and each doctor's role.
In addition to what Dr. Dharmarajan sir has mentioned, we have to, there is one other major factor with respect to diabetic foot ulcers are concerned. The thing is about infection, because this is the most common associated problem with respect to any diabetic foot ulcer. So any open wound is prone for being exploited by organisms from elsewhere. It can be from outside or it can be from within also. A simple ulcer, uninfected ulcer in the foot can get infected by a caries tooth that the patient has. So even that is possible. So it can be either from within or from outside. The most easier way of getting infected is from outside, because our patients have the habit of walking barefoot. So what do we do when we find infection in a diabetic foot is very important, because the general notion of public is that diabetic foot is being managed by dressings till it has gone to a reach where you cannot salvage the toe anymore, then amputation. So this is the common way of managing diabetes, which is not right. So what everyone should understand is, when they have a small ulcer, when it is infected, it is important to address it immediately and radically. Radically, I mean, it is almost like how we treat cancer. Okay, so we have to be that aggressive in treating an infection in a diabetic foot ulcer. So we have to clean that wound up and make it a reconstructable wound, which means we should get rid of all the dead tissue, we should get rid of all the infective material, we should get rid of all the unhealthy tissue. And once the wound is nicely healing up, at that time we have to put in a reconstructive tissue. So this is the basic principle around reconstructive or salvage of a diabetic foot ulcer. But how do we do it? There is a workflow, because when a patient comes to the hospital, so how do we address the patient? So we examine the patient, we find out where the ulcer is. As I said earlier, there is an imbalance in the biomechanics of the foot. So we also examine for where is the imbalance in the biomechanics of the foot. So because ulcer at the tip of the toe, which is already bent like this, will have an ulcer here. That is because of a tendon called flexor hallucis longus, because that muscle is tight. an ulcer at the base of the first toe because a joint here is a problem. So similarly, ulcer in the just next to the toes because the tendoachilles here, the long tendon here is very tight. So like that, certain areas, ulcers in certain areas will have a cause at certain places elsewhere, which is affecting that point of the foot, pressure exerted on that point of the foot. So we will assess the pressure points and where from the pressure points come from. Then we will assess whether it is infected, whether there is any pus coming out, whether there is any secretions coming out. So this is important because we need to test that tissue for what organism is present and which antibiotic should we give to counter that organism. So this is the test we commonly do it, which is called as wound culture sensitivity. So a tissue culture is any day better than just putting in a swab and taking a culture. So we cut a little bit of tissue and send it to microbiological examination where they tell us what is the organism that is causing the infection and which antibiotic should we give to counter that organism. It is important that we give the right antibiotic. We should not just start an antibiotic at random because this is a long process. So we will need multiple antibiotics during the course of the treatment. So we cannot misuse antibiotics here. So we need to find out what antibiotic will be helpful for this patient. So that antibiotic we have to use. Then we will assess the vascularity. We will look for the pulsations in the two arteries of the feet. So when the pulsations are affected, then we seek the help of a vascular surgeon. Then we assess the sensations of the feet. Then we look at if there is any pressure points that are causing this problem, and then we will think about releasing those pressure points by surgical means. Then we will assess the overall general condition and the glycemic status of the patient, which means the blood sugar levels, because all these need to be optimized to achieve a good result with the reconstruction. So next I would like to call upon Dr. Sai Vigneswar or Dr. Vishal to talk about how they achieve glycemic control in a patient who is due for a surgery, either a cleaning up surgery or a reconstructive surgery. How would they get the patient ready with respect to the medical management of the patient?
Right, so we're talking about, yes doctor.
Before that, I want to add on two misconceptions or ambiguities from the patient side as a common. When a patient comes to us in the early stage of an ulcer, after all this cleaning and wound management by plastic surgeon or our team doctors, the wound and the joint should be given a period of rest by way of immobilization in a plaster cast. So people think that already there is an ulcer, a plaster cast will aggravate that problem. It is difficult from our side to convince the patient, but it has been an evidence-based, time-tested procedure. This casting will prevent further breakage of the wound, keep the foot in rest, favor the wound to heal. Next conception is, once the biomechanics, the faulty biomechanics identified, we have to alter the biomechanics, architecture of the foot by lifting the toes or by lifting the bones, by restoring the arch, by offloading and then excision of bone fragments, dead bones, and then we have to put up metal screws or rods or plates inside. Again, patient will think that already there is a diabetic foot, we have an ulcer, we put a metal on it or inside, that will also aggravate the problem. It is not so. This type of recreating or altering the architecture is called super construct, that has been evolving since 10 years. The super construct means we immobilize or we fuse the joint beyond the pathology. Suppose the patient has got a midfoot problem, we go up to forefoot as well as the hindfoot. You understand? We include normal joints also. That prevents further problem like developing ulcers, or definitely it prevents an amputation.
So at Parvathy Hospital, we have designated and we have designed a proper workflow of once when the patient enters into the hospital per se, once the registration and every process is done, the first person that the patient is going to meet is a dietitian and a counselor. The patient is not going to meet a doctor in the first place, because the primary aim of us is to not take the patient for a surgery or for a secondary complication. The first process that we are going to try here is preserving our patient, preserving all the end parts of our patient. So the first part when the patient enters into the hospital is, once we have designed a personalized questionnaire for every patient, every kind of patients with varying level of HbA1c and varying sugar levels. So once the patient enters into the hospital, the patient will be visiting a diet cabin and a counselor, where he or she will be going through a select set of questions which will be designed, which will be tailor-made for that particular patient. So once he or she goes through that procedure, our dietitian will help them to have a proper knowledge on what's exactly happening to them, what they are supposed to do, and what are the particular set of doctors they are supposed to see. So then comes the part of the physician, where Dr. Vishal will come into the picture. So once they come to us, we will be able to assess how the patient has been treated so far, whether they were on any particular treatment per se, because in recent times the amount of naturopathy and allopathy interlinking and working is on the high, and each has their own sets of pros and cons. So we will assess the patient on what kind or what process of treatment they have been so far. So after assessing that, we will be going through their prescriptions. Is there any change in the prescription need to be done or not? And then we will be focusing on the complications that the patient is going to encounter in the future. That's when our food team is gonna come into picture. So the first thing that we are gonna say is the patient will be going through two tailor-made processes. One is gonna be a polio scan, where the pressure points of the patient, as Dr. Narayanamurthy sir, Prathap sir, and Dharmarajan sir insisted, the patient's foot will be assessed and the vascularity of it will be assessed. And the second thing is gonna be their visual things. So we will have an optometrist and an ophthalmologist in place, where they will be screened for retina and other related complications. So this is how the first step process will be.
So Dr. Vishal, I'll continue with you and your role.
So whenever we see, one more thing which we see usually will be whether the patient's sugars are controlled or not, and what are his old medications. And if we feel the patient is on improper treatment or treatment is not proper, his sugars are not getting controlled, we should try to change the medicines. And if the patient is having any ulcers or any other complications of that, we might also suggest insulin for a time being, so that if any wound is there, any ulcers there, that also starts healing. Because insulin being a very important thing, it helps in wound healing also, and it helps to reduce the sugars immediately. So tablets also work, but then for some patients, like a patient having an ulcer, having some sort of infections, we usually prefer insulin better than tablets, so that we get a better wound healing. And if the patient is also going to plastic surgeon, if he is planned for surgeries also, what we usually plan is, we usually try to stop the medicines, switch over to insulin temporarily till the surgical procedure gets over, and once patient is normal, we again restart his own medicines. So there's a usual workflow at what happens in the hospital.
So when the glycemic control is achieved, so the next is to reconstruct the vascularity of the limb, because this is the foundation on which every soft tissue reconstruction can be based. So unless the patient has good vascularity and nice blood flowing through the foot tissues, we will not be able to give an effective reconstruction. So for that we need the help of the vascular surgeon. So the next step will be to get the vascularity corrected before we get into the soft tissue part.
So diabetes and infection, it forms a vicious cycle. So once there is uncontrolled diabetes, the infection is going to rise, and once the infection rises, the sugars are going to go uncontrolled. So once these two factors are taken care of, my role as a vascular surgeon is to palpate the pulses. A diabetic with an absent pulse at the ankle, we call it critical limb ischemia. But critical limb ischemia is not equal to non-salvageability. So that is the common misconception that the patients have. So if they develop an ulcer, they think that they are going to get amputated. They will think about the socio-economic burden and everything else. So
I think there's a fear of amputation, and that's why they don't come to the hospital in the first place. So that is going to be the solution.
Yeah,
for the
so
problem.
that is how we have planned a system of PADAM, where each and every specialist will individually cater to the specific needs of the patient. So once the patient comes to us, we will palpate for the pulses, we will subject them to an angiogram, where we will see exactly where the blocks are, similar to what happens in the heart. So we can open up vessels by means of a small incision at the groin, so that the vascularity is restored. So once a palpable pulse is there at the ankle, we hand over the cases to the plastic surgeon, so that he will take care of their wound status simultaneously with the infection control and the diabetic.
So this is a very important point that everyone needs to understand, because timely surgery is very important. Every time when we offer a surgical procedure to a patient early in the stage of the treatment, they generally get scared about a surgical procedure being done, and especially when it is a major procedure like a vascular repair. But timely reconstruction and re-establishing the blood flow is very important in reconstructing the foot and salvaging the foot. So when the blood flow is established, we can plan a surgical procedure immediately to reconstruct the foot. If that is not established at the timely manner, like very early in the disease, when we wait for too long, when it is non-salvageable, sorry, when it becomes a non-salvageable food, then we will be left with no option but to amputate. So it is very important that early in the treatment phase, when a surgical procedure is offered, it is important to discuss with the surgeon about the merits and demerits of the procedure and decide judiciously.
So Dr. Narayanamurthy, I'll address this question to you and perhaps your colleagues can add on, which is what are the recent advancements when it comes to surgery in diabetic foot ulcer management, since that's the conversation that we've been having.
So diabetic foot ulcer management, generally you can divide it into three parts. First is whatever damage that has happened, we need to remove that. So damage control surgery, that we call as debridement or cleaning up procedure. So once we clean up all the dead tissue, devitalized tissue, infective tissue or infection related unhealthy tissue, once we have removed all that, then we go to the second stage of preparing the wound for a surgical reconstructive procedure. So once there are various techniques to address the preparing phase, and once we have prepared the wound for surgery, this can be a little longer duration, like about 1 to 2 weeks it can take. So once we have prepared the wound for surgery, then we reconstruct the wound. So reconstruction of the wound happens from tissue from somewhere else. So whichever part of the foot bears the weight, that needs to be addressed with a tissue called flap, which means that tissue comes with own blood supply, so that it is nicely vascular and blood flow is good at that point. So advent of microsurgery, the recent advancements, the advent of microvascular surgery has helped immensely in reducing the number of amputations that we've been doing earlier, because here once the vessel is reconstructed by the vascular surgeon, within 7 days we can actually use that reconstructed vessel where the pulses have come back after so many months. So we can use those vessels to connect a tissue from some other part of the body. We can just take the tissue from some other part of the body, cover the ulcer and connect those vessels to get them back to life again. So when we do such kind of a reconstruction, that reconstruction is more stable, and after the reconstructive procedure is done, it is important that they follow the post-operative protocol, which is a good compression garment, maintenance of the ulcer, moisturizing and maintenance, skin maintenance of the flap that we have done, a good compression garment and offloading footwear. So without good post-operative management with compression garments and offloading footwear, we will not be able to effectively give the patient a long-term rehabilitation period. So that is why at Padam, at our specialized diabetic foot clinic, we have all specialists with us who treat right from stage 1, where the screening of the diabetes happens, till the rehabilitation of the diabetic foot ulcers. So everything happens at one roof and at one place.
Yeah, regarding the vascular reconstruction, gone are those days where we have to do only open bypasses. So now we have drug-eluting scaffolds, drug-eluting stents, and then we call it POBA, only balloon angioplasties. So these can be done with a single needle hole at the groin. So these are the latest advances that the patient needs to know, and our motto here at Parvathy Hospital is we have to ensure salvageability of the limb at any cost. So that is what we call it as the amputation-free India project. So that would be our motto.
As Dr. Narayanamurthy sir said, during this staged procedures, one of the stages is putting some metals, implants, screws to lift the toes or to lift the foot so that the arch is not collapsing. And another thing patient may have, because of this bone joints are dropping towards the floor, that is called rocker bottom foot. Those things will happen. All these things will be prevented during one of the stages while they are doing microvascular surgeries. And as I earlier told, the recent advances is super construct. They need to include normal joints in front and back or in the sides so that further recurrence is prevented. This is the recent advance.
So to summarize surgical aspect, we have moved on from the days of just debridement and amputations being the surgical management of diabetic foot ulcers to foot salvage, early rehabilitation of the patient.
So maybe we can have some closing remarks from both of our the diabetologists and doctors of general medicine. Something you'd like to tell the public, misconceptions floating around. We'll have quick pointers from both of you as we close. Dr. Sai, we'll start with you.
Yeah, so if you ask me, the OG of misconception is something called diabetes reversal. So since it's a $1 trillion industry all over the world, many people try to take a bite out of it, and they advertise or they market something called diabetes reversal, which is very absurd. So there's nothing called diabetes reversal, because if you have to put a term called reversal, you're completely reversing the disease, and the patient will be disease free from there on. So what scientifically proven, or what the American Diabetes Association asks or says is there's only one thing called diabetes remission, and that too, that is only possible when the patient is having a type 2 diabetes and not a type 1 diabetes where the insulin is completely deficient. You have to put an insulin from outside for the patient or for the person to function. So when it comes to type 2 diabetes, how we can work on diabetes remission is there's something called ABC. So the patient should have an age which is something less than 35, which we technically say as an younger patient. A body weight, the patient should have some kind of body weight and muscle. We can't pick a lean patient for a remission. And C, which is called C-peptide. So C-peptide testing is something very important which has been done at the least in India, but the awareness of C-peptide has to be high, because only when you have a good amount of C-peptide in your body, the insulin secretion will be there. So when a patient is fitting into the criteria of young age with a good body weight and with a good amount of C-peptide, we can choose the patient for something called diabetes remission. So there's nothing called diabetes reversal, and if someone tells you that they are going to reverse your diabetes, you have to think twice before entering into it. And another misconception is, as Vishal has said, Narayanamurthy has said, Dharmarajan has said, there's something called the people are scared of insulin. If you ask the patient, like, you have to take insulin for a surgical procedure, or when our vascular surgeon Prathap says we have to take insulin for you to be surgically fit, patient runs away, because what patient feels is insulin is something is gonna carry in their genes and they are gonna transmit it to their next generation. It's not like that. Insulin is the most safest medication that you can ever take into your body for treating diabetes. That's why we, for a pregnant woman, even in her first trimester, which is a very delicate period, we start the patient on insulin because it's one of the most safest thing. So starting on insulin is not a crime. Starting on insulin is a more easier way of you handling the process or the procedure or the complication of the disease with least complication from medicine. So these are the two common misconceptions that people have and which people has to change.
Okay. Dr.
Yeah,
Vishal,
so there is one more misconception, that if I take tablets, my kidneys will be damaged. This is the most common misconception which I get, that if I'm taking diabetic medicine, people say that my kidneys will damage, I'll go into dialysis. So this never happens. So we have been treating so many patients and we never have seen any kidney damage as such because of medicines. So usually what we see is high sugars causing kidney damage rather than medicines causing kidney damage. And one more thing most people ask is, if I put insulin right now, whether I have to put it lifelong. So that is the most often misconception. So what we do is, any patients, any complications they have, we usually put on insulin for short term. Then probably we can switch out to medicines. And it's not that if you put insulin once, you have to put lifelong. It's not never like that.
Okay.
This is the most common reason which I see in the OP.
Okay, all right. Thank you so much, doctor, and thank you all of you for sparing your valuable time to join us here for this interview. And I'm sure those of you tuning in have also learned a lot as well, as we are chatting about diabetes with the expert team for Parvathy Hospitals here at Times Conversations. Thank you once again. Have a wonderful day, and to all of our viewers, thank you for joining us.